20 to 36 gray. And the toxicity that we expect really depends on the area that we're treating. For acute toxicities, things that we might see within 3 months of treatment, xerostomia, dry eye, esophagitis, fatigue, nausea, mucositis, and diarrhea are possible, but at most they're generally grade 1 or a few grade 2. We really don't see grade 3 toxicity, so it's probably not going to be that helpful for acute toxicities. Subacute toxicities that happen 3 months to 2 years out from treatment, like thyroid dysfunction, pneumonitis, pulmonary fibrosis, perhaps we might see a benefit with protons. Late toxicities, this is where we really think we can help patients. So, Hodgkin lymphoma patients, among all different cancers, are at the highest risk of developing late toxicity. This is a study from the Childhood Cancer Survivorship Group. They looked at outcomes amongst all different pediatric malignancies, and what you can see here is the risk of a grade of toxicity over time. The scale here is in years, so 30 years out from treatment, about 50% of Hodgkin lymphoma survivors are expected to develop a grade 3 or higher late toxicity. The types of toxicities they're developing are illustrated here. On the A panel, you can see disease recurrence. In the red line here, that's second malignancies. So at 30 years, about 15 to 20% of patients are developing a second malignancy. The blue line here is non-malignant second cancers. These are like meningiomas and DCIS. So together, this is about 30 to 35% of patients. And then on the scale on the C, you can see thyroid dysfunction remains a problem. And then in red here, this is late cardiac damage. So about 10 to 15% of patients developing significant cardiac damage. So these are the things we have to worry about in our lymphoma survivors. Now, although chemotherapy contributes to some of these problems, so does radiation. And this is a table of different studies that have been published that have tried to find some relationship between late toxicity and radiation dose to the different organs at risk. You can see that doses as low as 4 to 5 gray to the breast, lung, and thyroid have been associated with subsequent neoplasms in those regions. You can see that doses of 5 to 15 gray in the heart are associated with cardiac complications. So even low doses of radiation translate into these late awful toxicities. So as radiation oncologists, how can we help patients? Well, in lymphoma, we've lowered our radiation dose. So we used to treat with 45 gray, now we treat down to like 30 gray. We can use smaller radiation fields. We're not using the huge mantle fields that we used years ago. We now use smaller fields. Currently involved site radiotherapy is the recommended field design in the US. And we can use more conformal radiation techniques, including IMRT, arc therapy, and proton therapy. Now, the idea behind proton therapy is not, in lymphoma, is not a new concept. This is actually a publication back from 1974. This is even before I was born. But it took a while for people to actually start treating with protons for lymphoma. You can see here a color wash dose distribution for a patient with an anterior mediastinal lymphoma and potential benefits for protons. On the left, you can see the typical 3D conformal plan, which is just an APPA plan. In the middle is the IMRT plan, and on the right is the proton plan. You can see the axial images on top, the sagittal on the bottom, and the area in red is the high dose area. The moderate and low doses are green and blue. And so you can see a big benefit with protons in sparing the heart compared to either IMRT or 3D conformal. Again, as I said before, in the high dose area, we're not quite as conformal as we are with IMRT, but it's more than made up by the omission of the moderate and low doses. Here's another example. This is a 17-year-old that we treated with a stage 3 Hodgkin lymphoma, and you can see the different benefits here. So again, on the left, the 3D conformal plan, in the middle, an IMRT plan, and on the right, the proton plan. You can see significant cardiac sparing, as well as stomach sparing, and overall the body dose is much less. On the axial imaging, you can see how we're able to keep from going too far through the heart. And here's a third case. This was a 16-year-old female. You can see in this case how we're able to really spare the breast tissue quite nicely. Again, with protons, you can see here the omission of the breast radiation. While with IMRT, you get the low-dose bath, the 3D conformal, very high dose to the breast. And that's because the patient had axillary disease. So when I joined our Proton Center, I was tasked with trying to develop some evidence for using proton therapy in lymphoma. So we developed a study in which we prospectively evaluated patients with stage 1A through 3B Hodgkin lymphoma. After they had completed standard chemotherapy, we had them undergo a simulation, and then we planned 3 different treatment plans for them: a 3D conformal plan, an IMRT plan, and a proton plan. And then patients were offered treatment with the plan that looked the best. So this was a prospective study looking at dosimetry. Our guidelines for treatment planning are listed below. And I'd point out that our area of prioritization was we wanted to prioritize sparing the heart. And then after that, for women, it was the breasts, and for both lungs, and then thyroid. The primary endpoint for the study was actually to look at the overall body integral dose. So we enrolled 10, this is a little bit of an older slide. Ultimately, we enrolled 20 patients on this study. You can see the dose to the body was significantly reduced with protons compared with 3D conformal or with IMRT. The overall mean body dose was reduced by about 59% compared to 3D conformal and 53% compared with IMRT. So integral dose matters because that's what's going to lead to overall summation of second cancers and other late effects. Looking at dose reduction to the different organs at risk, you can see considerable that the mean proton dose to the heart was much lower than either 3D conformal or IMRT. Same with the lungs. The breast dose, you can see overall wasn't too significant, and that's because the majority of patients did not have axillary disease. But in those few patients that did have axillary disease that were females, we did see a much larger benefit. And then you can see the esophagus dose and thyroid dose. This is what the typical DVHs look like for the heart. Again, 3D conformal, IMRT, and protons. And again, I'm going to point out that we are a little bit more conformal with the IMRT plans in the high dose area. Where we do better is sort of the moderate and low doses with protons. And again, here's what the DVH would look like for the lungs for 3D conformal, IMRT, and protons. So there's actually been about 15 published studies that have just compared the dosimetry, similar to our prospective study, but they were all done retrospectively. And in every one of these studies, they have shown that proton therapy best reduces the dose to the different organs at risk for these patients. Beyond the mediastinum, you can imagine the benefits of using proton therapy in orbital lymphoma. Perhaps not for the indolent one where we're using 20 gray of radiation, but more for the more advanced ones where we're using 36 to 40 gray. You can spare the brain, the contralateral eye very well. Even amongst the Hodgkin lymphoma patients, we saw some additional sparing. In one patient, we were able to spare the brain, and that's important because there is increased risk of brain cancers with even doses of 10 gray of radiation. You can see again in one of our other Hodgkin lymphoma patients, again we were treating the mediastinum, but we had to treat the high neck on them too. That with protons we were able to spare the oral cavity in the patient versus if we had done the APPA plan or the IMRT plan. Neck sparing for these patients, you can spare a lot of the neck musculature and fat compared to either 3D conformal or IMRT. And that's important because there are some long-term follow-up studies. Again, these patients have generally been treated with higher doses of radiation in lymphoma, but you can see that they've had some neck and musculoskeletal issues 20, 30 years later, which we see in our lymphoma patients. GI sparing, so sometimes we need to treat the spleen in our lymphoma patients, And so these are two different plans where we actually were able to spare the liver very nicely and the stomach compared with either 3D conformal or IMRT. And in the periaortic setting, you can see that we're able to spare the stomach and bowel with protons versus a 3D conformal approach. And that's important because actually radiation-induced stomach cancers is something that has definitely been reported multiple times as a long-term side effect of receiving radiation to the abdominal area, especially amongst the younger patients. So we've talked about this nice dosimetry data, but what about actual clinical evidence? The clinical data is pretty new. We have our outcomes from our prospective study. Ultimately, we had 15 patients who were treated, and we had very good outcomes, 3-year event-free survival of 93%. We've also published our outcomes for our pediatric Hodgkin lymphoma patients. And then the Proton Collaborative Group, which again, as I said before, is a number of different proton centers throughout the US, including community and academic, recently published their results of 40 patients with Hodgkin lymphoma. I don't want to go over this data too much because, this is where the PCG sites are located. But what I want to do is this larger study that I recently did, in which I collaborated with the PCG centers and the University of Pennsylvania. We pulled all of our lymphoma patients to first look at who was being treated. And you can see the patients being treated with Hodgkin lymphoma are generally the patients with the mediastinal involvement, so that's where we expect to see the biggest benefit. Patients with bulky disease, B symptoms, and actually the average age for them was 20 years old, so it's the younger patients that are getting it. You can see the 3-year event-free survival. Overall, it's 92%, and broken down by the low-risk adults and pediatrics that are excellent, intermediate-risk adults and pediatrics, pretty good, and then high-risk patients, very good. And here it's broken down by the adults and the pediatrics. So overall, these outcomes are very favorable, very much consistent with what we'd expect with photons. We're not expecting better event-free survival with protons, but we're expecting to have just as good event-free survival with expectations of improvement in late effects. There were 9 relapses, and there have been concerns that we would expect to see more relapse in our proton patients because of the high conformality with protons. But we didn't see that. There were 9 relapses, 5 were in-field, and most of those were due to patients getting lower doses of radiation. The pediatric patients in the US get about 21 gray of radiation, and I don't think that's going to be sufficient. Even with photon-based radiation, they see that the primary area of recurrence after 21 gray of radiation is still in-field. So it's remarkable that only 1 patient who had an in-field relapse actually received 30 gray or more. We did have 3 patients who recurred in adjacent nodal stations. This was not an issue of proton therapy. This is more of an issue of perhaps using involved site radiation. So it's just above or below the treatment field. Using photons would not have improved the outcome in those cases. This is what the data looks like for proton therapy versus IMRT. So if we look at this pooled data, you can see we now have about as many patients as have been published for IMRT. Similar follow-up, similar recurrence-free survival, and similar toxicity, except for one study, and that's the study from MD Anderson, which was recently reported. In the study, they were using IMRT for mediastinal lymphoma and actually reported a 7% grade 3 pneumonitis rate. Actually very high, much higher than what we see with 3D conformal radiation, and actually kind of what we would expect to see on after 60 to 70 gray of radiation in a lung cancer trial. So this is sort of the one little blip. It may be because of the low dose volume of radiation they're receiving. Again, we didn't see any grade 3 pneumonitis, and we barely saw any grade 2. There have been some outcomes that have been reported for non-Hodgkin's, very small cohort of 11 patients, but local control was excellent, 91%, and they did not see any grade 3 toxicity. This study included orbital lymphoma, 3 primary mediastinal B-cell lymphoma, which are very similar to our Hodgkin lymphoma patients who are younger with mediastinal locations, and 2 patients with NKT cell lymphoma. So what about data for the late toxicities? We do not have much data on late toxicities, especially in the lymphoma world with protons. But we do have a little glimpse of evidence from this study that was published by the Harvard group. What they did is they took patients that they treated for all different types of cancers at their proton center, and they matched them with patients from a large cancer registry based on age, sex, treatment year, cancer histology, and site. And then they looked at the instance of developing subsequent malignancies. And what you can see here is that the photon group had about 2-fold higher risk of second cancers than the proton patients. And so this is sort of the best proof we have for our whole rationale of using protons in lymphoma, which is to reduce these late effects, the second cancers and the cardiovascular complications. Currently in the US, we are using it on a clinical trial. The COG study allows for proton therapy. And the NCCN Guidelines, this is sort of our cookbook of how to treat cancer in the US that you can access. They state here that treatment with photons, electrons, or protons may all be appropriate depending upon clinical circumstances. I'm not going to read any more of this, but basically they suggest that whatever modality spares the organs at risk the most is the modality that should be used because of all the evidence that we have about the harmful late effects of radiation. And so we should be doing everything possible to reduce that. So what do I do when I'm trying to consider who to use proton therapy in? I consider the patient's age, disease location, whether they're younger. I think these patients benefit more than the older patients. And then the location. In the mediastinum and abdomen, you expect to see more of a benefit than maybe in the cervical neck, where IMRT could do a great job. Also, we have to consider the difficulties of patients having to travel and potentially pay for treatment, so we need to factor that in as well. So with that, I'd like to thank the group. I ended early, but again, if anyone has any questions, I'd be